Hello, I am Dr. Nanette Winger, and I'm delighted to be here today to recognize the winner of the inaugural Dr. Nanette K. Winger Research Goes Red Award for the best scientific publication on cardiovascular disease and stroke in women. This award is a new AHA award, which will be given annually in recognition of the best research article focused on cardiovascular disease and stroke in women published during the previous year in any of the association's 14 peer-reviewed scientific journals. AHA Research Goes Red initiative aims to empower researchers to contribute to heart health research for women. This award allows us to highlight the continued focus needed on women's heart health research. The Dr. Nanette K. Winger Award is sponsored by the AHA's Research Goes Red. This aims to realize that cardiovascular disease contributes to a woman's greatest health threat, claiming the lives of 1 in 3 women. That's a third of all mothers, sisters, daughters, friends, neighbors, and loved ones. Research Goes Red is a collaboration between consumers contributing to health research, the American Heart Association volunteers and health experts, and Verily with its leading and tools and technologies. As we all know, in the past, clinical research studies have not been adequately inclusive of women or have not analyzed women's specific heart health data. Yet that is the best way to improve care and prevent heart disease. Together, we aim to change these statistics and help save the women we love. It's an honor to have an award that bears my name. As a leader in the field of women's heart disease and an advocate for women in cardiology and medicine, I've been at the forefront of advancing patient care for over 60 years and was one of the first physicians to recognize coronary disease in women and to evaluate the different cardiovascular risk factors, symptoms, and conditions for women compared to men. I had the incredible opportunity to pave the way, supporting and mentoring women as scientists and medical professionals, as well as pioneering efforts for cardiovascular disease research about, for, and by women. The new Nanette K. Winger Research Goes Red Award will serve as an inspiration for continued innovation and discovery and research on cardiovascular disease and stroke in women. We hope it will continue to motivate the current generation of scientists and medical professionals and many more generations to follow. The winner of the 2021 Nanette K. Winger Award is Dr. Claire Oliver Williams for her manuscript, Future Cardiovascular Disease Risk for Women with Gestational Hypertension, a systematic review and meta-analysis published on July 7th, 2020 in the Journal of the American Heart Association. Of the 54 eligible manuscripts that were peer-reviewed, 14 countries were represented and 61% of the first authors were women. Papers were graded based on scientific impact, innovation, methodology, and quality of the data and evidence supporting the hypothesis and the conclusions. Now let me tell you about Dr. Williams. Dr. Claire Oliver Williams is a public health clinician who is a graduate of Cambridge University, where she earned both a Master's of Public Health and Epidemiology and was awarded her PhD on the topic of pregnancy loss and maternal risk of cardiovascular disease. She led this research as the recipient of a junior research fellowship at Homerton College, a constituent college of the University of Cambridge. And she is now an honorary research associate in the Department of Public Health and Primary Care at the University of Cambridge, both in Cambridge, England. Dr. Oliver Williams is also a specialty trainee registrar in public health for the Central Bedfordshire Local Authority. She has received numerous awards and grants, including from the British Cardiovascular Society, British and Irish Hypertension Society, ESHRE, and the British Heart Foundation, and has published more than 50 papers, including in JAMA Circulation and JAMA Cardiology. She is passionate about outreach and patient engagement. As such, she has been awarded funds to commission artwork based on her research, which will be installed at Peterborough City Maternity Hospital. Dr. Oliver Williams researches cardiovascular risk factors that are specific to women. She is currently exploring the effects of reproductive health on other health conditions, specifically how cardiovascular risks may be identified from a patient's obstetric health histories. Dr. Oliver Williams, thank you for being with us here today. We are looking forward to your presentation.
Good afternoon, and thank you so much for the opportunity to speak to you today. It was an absolute pleasure to find out that I've been awarded the Dr. Nanette K. Wenger Award for my research paper, The Future Cardiovascular Disease Risk of Women Who Had Gestational Hypertension, a Systematic Review and Meta-Analysis. Thank you so much to the American Heart Association for inviting me here today, and for Dr. Wenger for all her incredible work that she's been done. So I'd like to put forward my presentation to you all on gestational hypertension and cardiovascular disease. Now, 36 years ago, my mother, who is seen here, you might recognise her, she looks a bit like me, was pregnant with me. I am her third child. I have two older sisters, and in each of those pregnancies, she developed gestational hypertension. Now, after giving birth to my two sisters, her gestational hypertension went away. However, after giving birth to me, it remained. Now, read into that whatever you will. Now, back in the 1980s, as it was, she was prescribed antihypertensives after the gestational hypertension turned into chronic hypertension, and she was sent on her way to be monitored by her primary care physician. However, now that I am in this area of research, I know that she's at higher risk of cardiovascular disease. And I know that this is very important, but I have a question to put forward to you all. Do we tell women who've experienced these pregnancy complications that they're at higher risk of cardiovascular disease in later life? And if so, what do we do to support them after that? Now, in my talk, I'll cover three broad areas. To begin with, I will start with the history of the relationships between pregnancy complications and cardiovascular disease. So looking at the origins of them in previous research and possible mechanisms underlying the relationship. Next, I'll move on to the research that I won this wonderful award for, and also other work that I've done in this area. And finally, I'll give you a little sneak peek of what I'm working on at the moment. So let's start with the history of pregnancy complications and cardiovascular disease. Now, approximately 13% of pregnancies are affected by hypertensive disorders of pregnancy. And what do I mean by that? Well, there are four different types. There is chronic hypertension, which I'm sure you're all familiar with. There is gestational hypertension. That is the new diagnosis of hypertension after 20 weeks gestation. There is preeclampsia, which is also the new diagnosis of gestational hypertension, after 20 weeks pregnancy. But in addition, there are other severe biological and biochemical disturbances, including things like protein in the urine. And finally, we have preeclampsia superimposed onto chronic hypertension. Now, my talk will focus mainly on gestational hypertension and preeclampsia. But these are serious conditions. In fact, gestational hypertension and preeclampsia are the leading causes of morbidity and mortality for pregnant women and infants worldwide. And the prevalence of these conditions varies by many different factors and across the world. And some of the highest prevalences are found in Africa. Now, research in this area has been going on for quite a while, as I'm sure many of you will know. The first papers that I found relating to pregnancy complications and future cardiovascular disease risk in the mother were found back in the 1950s and 1960s. And here we have this figure, which is produced from data from PubMed. So this is the number of papers that were published looking at cardiovascular outcomes for mothers who've had pregnancy complications. And we can see they go back quite far, but really the renewed interest and awareness of it really increased in about 2000 onwards, so in the past 20 years. And it's acknowledged there's an increased risk of a number of cardiovascular outcomes for several different pregnancy complications. And that's summarised here. So preeclampsia, preterm birth, gestational diabetes, and gestational hypertension are all associated with an increased risk of cardiovascular disease. Similarly, they're also associated with an increased risk of coronary heart disease, as is recurrent miscarriage. Whilst with stroke, there's an increased risk for women who have had preeclampsia, preterm birth, or gestational diabetes. And once again, unfortunately, women who've had preeclampsia are at higher risk of heart failure. Now, there's been a wealth of research in this area, and as a result, these kind of various factors have been included in guidelines about the prevention of cardiovascular disease in women. And these are across many different countries in the world, New Zealand and Australia, France, UK, the USA, Canada, and international guidelines. And a lot of the different recommendations that come out of them are summarised on this slide here. And they include counselling women about their cardiovascular disease risk, annual cardiovascular risk factor checks for women, referral for multidisciplinary care, and clinicians taking detailed history of pregnancy complications in later life. And what might be underlying these links between pregnancy complications and cardiovascular disease? Well, this figure here was produced by Sitar and Greer back in 2002. And this is one way that it can be conceptualized. And what they proposed is that, in fact, pregnancy complications highlight a pre-existing predisposition to cardiovascular disease. So those who've had pregnancy complications such as preeclampsia are seen in the red line on that figure, and those who have not, the so-called healthy population, are in that blue dotted line. So pregnancy complications are a result of pre-existing adverse levels of cardiovascular disease risk factors. These are subclinical, but during pregnancy, those extra physiological demands result in them becoming apparent. Once the pregnancy ends, they become subclinical again, but over time, as the women age, there's an increased risk of developing cardiovascular disease in later life. But of course, this isn't the only theory that exists that links pregnancy complications to cardiovascular disease. It may be that some pregnancy complications, including preeclampsia, which is especially severe, may cause some kind of damage to the vascular system, which predisposes a woman to cardiovascular disease in later life. And of course, it may in fact be that there's a combination of both of these theories, that it's a pre-existing predisposition and some damage is caused in pregnancy that underlies the observed relationship. So having covered kind of the background and possible mechanisms, I'll go on to kind of my contemporary work, including the paper that I won this award for. And I can't reiterate again what a pleasure it was to find out about it. So my paper was called Future Cardiovascular Disease Risk for Women with Gestational Hypertension, a Systematic Review and Meta-Analysis. Now you might be wondering, given the wealth of research that I've just summarised and the inclusion in guidelines, what prompted me to conduct this research? Well, at the time that the research was conducted, gestational hypertension wasn't included in many of these guidelines, including those of the American Heart Association. And furthermore, there hadn't been a systematic review that comprehensively combined the risk, assessed the risk of a range of cardiovascular outcomes for women who had gestational hypertension. So my colleagues and I took it upon ourselves to do that. We searched through 7,000 abstracts derived from multiple different databases and identified 21 studies that looked at the relationship between gestational hypertension and some form of cardiovascular outcome. And that included total cardiovascular disease, coronary heart disease, stroke, heart failure, and thromboembolic events. In total, this resulted in about 3.5 million women included in our review, and around 127,000 of those had a history of one or more pregnancies affected by gestational hypertension. There was variable study quality that was found. 5 studies were of high risk of bias, as assessed by the Newcastle-Ottawa scale, and 10 studies were poorly adjusted. Now, it should be pointed out that those 21 studies that we identified, they categorised the exposure of gestational hypertension in different ways. Some looked at whether a woman had gestational hypertension in their first pregnancy and compared risk to those women who had a normotensive first pregnancy. Other studies looked at whether women had a history of one or more pregnancies affected by gestational hypertension and compared to women who had no pregnancies affected by gestational hypertension. To avoid any statistical heterogeneity, or to minimise it at least, we decided to keep these 2 different groups of exposures separate from each other. So here we have the results of the meta-analysis looking at the risk of number of cardiovascular outcomes for women who had gestational hypertension in their first pregnancy. We deemed it possible to conduct a meta-analysis if there were at least 3 studies assessing the risk of a particular outcome. And so we have cardiovascular disease up at the top, then coronary heart disease, stroke, and thromboembolic events. And we can see that women who had gestational hypertension in their first pregnancy were at a 45% higher risk of cardiovascular disease in later life and a 46% higher risk of coronary heart disease. There was no statistically significant higher risk of stroke found, and there was no evidence of a higher risk of thromboembolic events. Now, my colleagues and I theorised that if there was an intervention that existed that was entirely effective at mitigating these increased risks, and it was delivered to women shortly after an effective pregnancy, how many cardiovascular and coronary heart disease events could be averted? So we calculated the attributable risk increase in order to assess that. And we found that there was 8.6 cardiovascular disease events per 1,000 woman years that could be averted, and 4.2 coronary heart disease events per 1,000 woman years that could be averted if these interventions existed and they were delivered in a timely fashion to women who had gestational hypertension in their first pregnancy. Now, moving on to that other exposure I mentioned, that is women having one or more pregnancies affected by gestational hypertension, and looking at a risk of 4 outcomes. Now, it was possible to conduct meta-analyses for cardiovascular disease, coronary heart disease, stroke, and heart failure this time. And what we found is that women who had one or more pregnancies with gestational hypertension were at 81% higher risk of cardiovascular disease, 83% higher risk of coronary heart disease, and a 77% higher risk of heart failure, but no statistically significant higher risk of stroke was found. And once again, we calculated the attributable risk increases in overall cardiovascular and coronary heart disease, and found that if there was an effective intervention out there, then 15.6 cardiovascular disease events per 1,000 woman years could be averted, and 7.6 coronary heart disease events per 1,000 woman years could be averted. Now, of course, our systematic review and meta-analysis had a number of limitations. This included a lack of dose-response relationship being assessed. We only found 2 studies that included any analysis of a dose-response relationship, and both of them provided unclear evidence. And most, unfortunately, of the meta-analyses had a high heterogeneity found, and this might be due to a number of different reasons, but it could be the study designs differed between, study designs were combined differed, different methodologies used, and also different populations. And of course, some of the studies were of poor quality. There were 5 studies that were high risk of bias and also 1 at moderate risk of bias. When we restricted analyses down to only those that were high quality studies, those were at low risk of bias, that is, we found the results were materially unaltered. Now, given what I've just said about the lack of a dose-response relationship and that there was a limited number of studies out there assessing some of these outcomes, we took it upon ourselves to conduct a primary analysis of the relationship between cardiovascular outcomes and gestational hypertension. And in order to do so, we applied for funds from the British Heart Foundation in order to access electronic health records from England. And so we did manage to get this funding, and we have accessed this electronic health records, which run from 1997 to 2015. They're NHS data, and one of the advantages of that is, of course, that NHS care is free at the point of access. So the vast majority of women in England who gave birth in NHS hospitals and are included in this data set. The data set includes 2.5 million women. There's a wide range of cardiovascular outcomes. And of course, the dose-response relationship can be assessed. And when I say there's a wide range of cardiovascular outcomes, here are the ones that we analysed. It's 20 hierarchical outcomes. Overall cardiovascular disease, then broken up into subtypes and subtypes and subtypes of subtypes as well. Now, these outcomes were identified from ICD-10 codes, as were gestational hypertension and preeclampsia. Now, another one of the great advantages of having sort of nationwide data as we have is we can assess the incidence over time of very relevant diseases. And here we have the incidence over time on the left-hand side for preeclampsia and gestational hypertension. Now, preeclampsia is that bluey greenish colour. The line is the crude incidence, and the bars are the absolute number of cases or affected women. Whilst the sort of orangey red colour, that is gestational hypertension. And we can see the crude incidence, that line, decreases for gestational hypertension over time to about 2007 before it increases again. But the crude incidence is reasonably stable over time for preeclampsia. Now, if we look over on the right-hand side, we have the incidence by age with the same colouring as before. And of course, the crude incidence increases with age. That perhaps is no great surprise, although the largest number of cases come from women who between the ages of 27 and 30, as this was the average age at giving first birth in this data set. And we can also assess incidence of cardiovascular disease by time and age as well from this data set. And we've segregated it here by normotensive women, women who have preeclampsia in their first pregnancy, and women with gestational hypertension in their first pregnancy. Normotensive women are seen in red. Those in blue had gestational hypertension, and those in preeclampsia those in purple had preeclampsia. Now, on the left-hand side, we have cardiovascular disease incidence over time, and it's no great surprise to discover that the incidence is higher for women with gestational hypertension and preeclampsia. But what perhaps is rather interesting to note is that the lines diverge away from normotensive women just in a few years after an effective pregnancy. And similarly, over on the right-hand side, when we have the incidence by age, we see that by the age of about 25, the cardiovascular incidence for women with preeclampsia and gestational hypertension is higher than women who had a normotensive first pregnancy. So very early on, these differences are noted. And so moving away from the descriptive look at things and actually assessing the risk of cardiovascular outcomes. First, we have for women with gestational hypertension in their first pregnancy compared to women with a normotensive first pregnancy. And what we can see is that there is a high risk of coronary heart disease, angina, in particularly stable and unstable angina. There's a high risk of heart failure, of dilated cardiomyopathy, ischemic stroke, and hemorrhagic stroke. And of note, there's more than a twofold high risk of dilated cardiomyopathy, which is remarkably high. Now, we did the same thing looking at women who had preeclampsia in their first pregnancy compared to women who had a normotensive first pregnancy. And we could see that the women with preeclampsia had a higher risk of coronary heart disease, stable angina, acute MI, dilated and hypertrophic cardiomyopathy, ischemic stroke, and intracerebral hemorrhage. And notably, there was more than threefold higher risk of hypertrophic cardiomyopathy and twofold high risk of dilated cardiomyopathy and acute MI. Now, that was all summarising the risk over the 18-year time period of this data set. But when we break it down and look at the risk of overall cardiovascular disease by time, we see it's relatively stable for women who had gestational hypertension in their first pregnancy, which is on the left-hand side. But there seems to be an increasing magnitude in risk for women who have preeclampsia in their first pregnancy. And I mentioned before, one of the motivating factors for this research was perhaps looking for a dose-response relationship, which is what we did next. So we looked at whether the number of pregnancies affected by gestational hypertension was related to the magnitude of risk of these cardiovascular outcomes. It should be noted, unfortunately, that there was a loss of power when looking at some of the rarer outcomes, such as AAA. So not every single outcome could be assessed in relation to a dose-response relationship. When we look at the figure on the left-hand side, we have the different outcomes. And then after that, we have the number of pregnancies affected with gestational hypertension, which is categorized as 0, 1, or 2 or more. So we found the magnitude of risk increased with the number of affected pregnancies, number of pregnancies affected by gestational hypertension for total cardiovascular disease, more specifically, coronary heart disease and ischemic stroke. And in particular, women who had 2 or more pregnancies affected by gestational hypertension were at more than 3 times higher risk of ischemic stroke than women who had normotensive pregnancies only. And the same kind of analysis was conducted for women who had preeclampsia, looking at the number of pregnancies affected by preeclampsia. And we can see that the magnitude of risk increases for the number of affected pregnancies for total cardiovascular disease, coronary heart disease, and in particular of the strokes, hemorrhagic stroke. And for all of these 3 that I've just mentioned, women who had 2 or more pregnancies affected by preeclampsia are more than 2-fold higher risk of these outcomes. Now, a dose-response relationship, as we see here, can be conceptualized in a few different ways. We can look at the number of affected pregnancies, but we'd also look at just one affected pregnancy and how severely affected it was. And that's what we decided to do next. So ICD-10 codes differentiate between severe preeclampsia and mild or moderate preeclampsia. And so looking back at that first pregnancy that we were looking at before, we conducted a different dose-response relationship, seeing if the magnitude of risk changed according to the severity of preeclampsia in that first pregnancy. So once again, we have the outcomes on the left-hand side, and then after that column, we have the preeclampsia diagnosis in the first pregnancy. That's normotensive, mild or moderate preeclampsia, or severe preeclampsia. And we found the magnitude of risk increased for total cardiovascular disease and also cardiomyopathy, all strokes, specifically ischemic stroke and intracerebral hemorrhage. And for ischemic stroke and intracerebral hemorrhage, the risk was 2 to 3 times higher. But for cardiomyopathy, for women who had 2 or more pregnancies affected by preeclampsia, there was more than 4-fold higher risk. Now, this all looks very nice and comprehensive, hopefully. But if we go back to thinking about that systematic review that I mentioned earlier on, there were some limitations to it. There was a lack of dose-response relationship, which we've now looked at in this primary analysis. But there were other issues that me and my colleagues noticed, and that included where those studies were conducted and in which populations they were studied. So perhaps it's no great surprise for many to discover that there is a bias involved in a lot of research. And a lot of research is conducted in high-income countries and predominantly white populations. And to highlight this in my own area of research, my colleagues at the University of North Carolina at Chapel Hill and I looked at all the papers that we could identify that assess the risk of cardiovascular disease outcomes for women who had gestational hypertension or preeclampsia previously, and looked at them in relation to both ethnicity and also which countries or continents the work was carried out in. Now, we identified 34 studies, and as you can see from that pie chart, the vast majority were from Europe, with 18 studies identified, 9 from North America, 2 from Australia, and 5 from Asia. All bar one of these studies was from a high-income country. Only one study from a low or middle-income country was found, and that was from Iran. Now, when we looked a little bit further to visualize what this was, we produced this figure here. Now, this is not a meta-analysis, it's just a way of visualizing all the different studies and the results. We color categorized the different studies to highlight where they came from. So those black lines and boxes are European studies, the red ones North American, green Australian, and blue are Asian. But we also looked at ethnicity as well. And, we looked at 4 different outcomes: cardiovascular disease at the top, coronary heart disease, heart failure, and then stroke. And That last column there on the left-hand side highlights the ethnicity of the populations that were looked at. So if the population was more than 80% dominated by one ethnicity, we deemed it to be that ethnicity alone. So those white studies of white populations that we see, they had 80% or above of the population were white women. Of all those studies that we identified, the vast majority were from white populations. There was one of African American women and two of studies of Taiwanese women. Others were of mixed ethnicity, but no stratification was provided, or no information about ethnicity was available in the study. And when we look at the studies that evaluated the risk after gestational hypertension, if anything, the results are a little more depressing. The vast majority were from the studies were conducted in Europe or in North America. And only one study was provided a non-white, non-mixed or unknown ethnicity, and that was one Taiwanese study, unfortunately. So this is a sorry state of affairs, I'm sure we all know. But I'd be remiss not to notice that the very large data set I have of electronic health records could provide some way of analysing all of the, of addressing this issue, of looking at the relationship between gestational hypertension and cardiovascular outcomes, or preeclampsia and cardiovascular outcomes among different subpopulations of women. And so my colleagues and I have started working on this. So that NHS electronic health record data set, 80% of the women in there are white. We have around 6% are Black African or Black Caribbean, around 13% are Asian, and the rest are either unknown ethnicity or another ethnicity. Now, we've conducted some preliminary analyses, which we'll share with you here, but I should really emphasize the fact that they are preliminary, they are not the finished work. The categorization of ethnicity is not ideal, it is heterogeneous, and we're working on doing further stratification to have more nuanced understanding of the risk in these different populations. So really this isn't the final product, but however, it will hopefully speak to what our drivers and motivators are for continuing this work. So let's look here at the rate of cardiovascular disease over time for women who had gestational hypertension, that's those in the lighter grey, and those who had normotensive first pregnancies, those in the darker grey. And we've grouped them by into three different groups. Over on the left-hand side, we have the results for women who are Black African or Black Caribbean ethnicity. We have Asian women in the middle, and we have white women over on the furthest right-hand side. And what we can see here is a number of different things. We can see that the rate of cardiovascular disease for women of Black African and Black Caribbean ethnicity, it diverges for women with gestational hypertension away from those who had a normotensive first pregnancy. There's divergence over time. Whereas this is not found for women of Asian ethnicity or white women, where both of those lines are roughly parallel over time. Furthermore, there is less clear differentiation of the rate of cardiovascular disease for Asian women between those two groups of normotensive women and those with gestational hypertension. Now looking at the same thing, rate of cardiovascular disease, but by preeclampsia now. So there's light grey lines and blocks, they're for representing women who have preeclampsia in their first pregnancy. On the left-hand side, for Black African and Black Caribbean women, we see there really isn't any clear differentiation of the rate of cardiovascular disease between these two groups, whereas there is much clearer differentiation for Asian women and white women. And for white women, it does seem to be a divergence in risk over time as well. And then we can look at the risk of those many outcomes that I discussed previously. I appreciate this is a very busy slide, so we'll go over it in a piecemeal fashion. Looking over on the left-hand side at women of Black African and Black Caribbean ethnicity, we can see that those who had gestational hypertension in their first pregnancy were a more than twofold higher risk of total cardiovascular disease compared to women who had normotensive first pregnancy. But when we look at those different subtypes, we find that there is markedly higher risk of many different outcomes, including coronary heart disease, more than twofold risk of coronary heart disease and heart failure, more than threefold higher risk of hemorrhagic stroke, specifically subarachnoid hemorrhage, and a more than fourfold, nearly fivefold in some cases, higher risk of angina, particular unstable angina, and cardiomyopathy. Now, moving into the middle, where we're looking at Asian women who had gestational hypertension in their first pregnancy compared to Asian women who had a normotensive first pregnancy, we see that gestational hypertension was associated with a 45% higher risk of cardiovascular disease. And looking at the different subtypes, we see there's more than twofold higher risk of heart failure and more than fourfold higher risk of acute MI and a nearly fivefold higher risk of intracerebral hemorrhage among Asian women who had gestational hypertension in their first pregnancy. And finally, looking at the last column for white women, see that white women with gestational hypertension in their first pregnancy had roughly 41% higher risk of total cardiovascular disease compared to white women who had a normotensive first pregnancy. And of those different subtypes, we see more than twofold higher risk of cardiomyopathy, specifically dilated cardiomyopathy, and increased risk of angina and stroke as well. Now, the same analysis was conducted, but looking at preeclampsia. So I should probably highlight that in case anyone was wondering why there's different numbers of outcomes for some of these different ethnicities, it's because there are smaller numbers in some of these different groups, and therefore we have loss of power, and it's not possible to evaluate the risk for some of the rarer outcomes. But going back to the risk of cardiovascular outcomes for women who have preeclampsia in their first pregnancy, let's focus again on the left-hand side, looking at Black African and Black Caribbean women who had preeclampsia in their first pregnancy compared to Black African and Black Caribbean women who had a normotensive first pregnancy. And what perhaps is remarkable is that no statistically significant increased risk was found for any of those outcomes. Myself and my colleagues were surprised to discover that, and I'd be very interested to hear if anyone has any thoughts or ideas about why a lack of positive association is found in this group, what might be underlying it. Moving on to Asian women in the middle, we see that Asian women who have preeclampsia in their first pregnancy were roughly twofold higher risk of total cardiovascular disease compared to Asian women who had a normotensive first pregnancy. And of those different subtypes of note, there was a more than threefold higher risk of acute MI, and shockingly a more than sixfold higher risk of intracerebral hemorrhage. And finally, looking at white women at the end, we find that white women with preeclampsia in their first pregnancy had a 59% higher risk of total cardiovascular disease compared to white women who had a normotensive first pregnancy. And notably, 2 to 3-fold higher risk was found of acute MI and dilated and hypertrophic cardiomyopathy for white women who had preeclampsia in their first pregnancy. Now, that concludes my sneak peek for the future work that I'm working on. What can we conclude from all this? Well, that there's a higher risk of cardiovascular disease after gestational hypertension and preeclampsia. That probably is no great surprise to many of you. But what is interesting is to note the really heterogeneous magnitude of the associations across a range of acute and chronic cardiovascular disease. And also we've identified presence of dose-response relationships for a number of cardiovascular outcomes, both for the number of pregnancies affected by gestational hypertension and preeclampsia, and also by the severity of pregnancy, the severity of preeclampsia in the first pregnancy. And finally, we've also highlighted that actually stratifying these risks by ethnicity is really warranted. There does seem to be discrepant risks in different ethnic groups, and further investigation of this is needed. And I just want to take a moment to cycle back to my original question that I mentioned at the beginning. So we're aware of these risks as researchers, as clinicians, we know about them, but often these risks are not being articulated to women. Do we tell them? Should we be making this much more routine and much clearer? And if we do, how do we support them? At what point do we tell them? There's a lot of questions surrounding this, and the impact of this information on individual women could be huge in both a positive sense and in a negative sense. It deserves a lot of deliberation, in my opinion. I'd just like to take a moment to acknowledge my funders and all of my wonderful colleagues here across the world. They are, and they have been absolutely fantastic. I should highlight that a lack of photos does not indicate less involvement or input in this research. It was merely the photos that were available on the internet at the time. And of course, I'd like to thank the American Heart Association once again for this wonderful award, and to Dr. Nanette Wenger herself for all of her fantastic work over her career. And finally, thank you to all for your time. And please do reach out if you have any thoughts, any questions, or if you'd like to collaborate on this work involving looking at different looking at risk in different ethnic groups. I always welcome collaborations with people who are passionate about this area of research. And my email address is there should you wish to reach out to me. Thank you very much for your time.
Let me first thank you for an absolutely elegant presentation. And as all scientists do, what you've done is you've raised more questions than you've provided answers. But let me ask you one or two things relative to the population that the American Heart Association knows best. And that is the US population, where what we've learned is that the cardiovascular health status in the US of pregnant women is worse than that of comparably aged non-pregnant women. So that women are coming to a pregnancy with poor cardiovascular health. And this is as measured by LifeSimple 7. So what advice would you have first for the young women? Because likely it is comparable in a number of other countries.
Well, firstly, thank you for that very generous compliment. I'm not sure my presentation was that slick when you could see my notes, but thank you anyhow. In terms of advice to young women, in all honesty, I don't think that cardiovascular disease is high on the priority list for women. I don't think that, certainly in my country, there's a lot of awareness that actually it's the leading cause of death amongst women in our country. I think there's a lot of focus on other diseases which are undeniably important, but as a result, cardiovascular health often gets knocked down the pole, so to speak. But having said that, I think clinically and academically there's increased awareness of the importance of pre-pregnancy health. Now, if that can then be articulated and communicated well to young women, that being cardiovascular healthy or, cardiometabolically healthy more broadly is important, not only for your own health, but for your chances of conceiving and having a healthy pregnancy and a healthy child, then I think we've got a really strong message there. But the tricky thing is getting that message out to these women, because of course younger women are less likely to attend primary care, for example, because they have fewer health needs. So perhaps one of the messages needs to be to start young and get young women when they're at the latter end of education, emphasizing the importance of cardiovascular health. But really, I think it's a really, really tricky message to get out there, and to get out there importantly, not only because loads of pregnancies are unplanned. So it's all well and good sort of emphasizing that before you get pregnant, get healthy. But if people aren't planning to get pregnant, but they become pregnant, that's something else to manage as well.
Let me follow up with another question until we get some more from the audience, please. You know, the concept of a fourth trimester of pregnancy is one that has gotten increased acceptance, both from the general community and particularly from the OBGYN community, with the idea that a number of health issues can be addressed postpartum and probably can reflect the problems that have occurred intrapartum. What would you advocate for our OBGYN colleagues and their patients to do if they have had gestational hypertension or if there has been preeclampsia?
So obviously, I mean, I'm not an OBGYN myself, so I can't speak as to what they do currently. But I do think that, having spoken to women myself after they've given birth and when they found out what my area of research is, I think there is an appetite for an understanding of the risks associated with gestational hypertension and preeclampsia if they are done tactfully and in a way that is empowering to women, where they feel they can take control of their cardiovascular health. So I think there's certainly scope for discussions and empowering information to be given to these women. And I think that that's going to be key, is the empowering aspect of these things, because really you don't want this to be another stick to beat women over with. You know, I have 2 children myself, and sometimes the last thing you need to hear after having given birth or had pregnancy complications is that, well, actually you've dealt with that now, but now you've got to deal with something else. You've got to deal with the fact that that indicates you're at a higher risk of cardiovascular disease in later life. That's not helpful to people. So it's going to be very, very delicate, tactful conversations, I think. But I don't think it should be reduced down to the OBGYNs, really. I'd love to see kind of that more multidisciplinary care that's referenced in many of the guidelines. But actually, we need to, yes, those 3 months after pregnancy, when you're more likely to have contact in the UK with health visitors as well as the GPs. I'm sure it works differently in other countries. But beyond that, or, you know, taking those histories of pregnancy complications for older women to see if that can helpfully highlight individuals.
The chat room has just emphasized to you that it was an excellent talk, and thanking you for sharing your journey and actually for suggestions for future research. So again, excellent achievement from the chat. Let me ask you a few additional questions. In your databases, can you ascertain the effects of blood pressure control during pregnancy? Is there anything in your data set that can suggest the optimal level of blood pressure during pregnancy, and whether, if hypertension is present, there should be lifestyle interventions or medications or what have you? What is available in the data sets you've examined?
So mine is hospital data only. So this is one of my bugbears about British data. As much as we have like wonderful nationwide hospital data, we do not have the reciprocal in primary care. And even worse, to my knowledge, we have no electronic health records for midwife-led care. So we don't have that information, Dr. Winger, and it's a huge loss. It's a huge loss not to be able to bring in kind of the midwife notes where you do have your blood pressure taken on a regular basis, or to bring in kind of that nationwide primary care data. We have smaller sets of primary care data, and some people have linked that to hospital data, and so therefore you can potentially look at blood pressure, you know, after a preeclamptic pregnancy and see how well, you know, that is controlled. There might be some women who have measurements before pregnancy, but it's unlikely given the ages of the people we're talking about. So you've hit on a really important point, and it's a huge gap in the UK data that we have. Maybe the Scandinavians do it better. They're always having amazing data, so perhaps they're the ones we need to talk to.
Well, you know, of the people listening to you, certainly a number are epidemiologists, but many are clinicians and clinician researchers. And let me ask you to identify, for perhaps the early career researchers, how would you approach the gathering of important relevant data for this population? How would you look at electronic health records, which I think our Scandinavian colleagues have and we have available in the US? What are the questions that you would ask, and what are the directions you would explore?
So obviously I touched a little bit upon my next steps, and I am very much interested in health inequalities. That's a personal interest of mine, and that's where I'd want to go. But really, I do wonder if we're reaching to some degree a bit of kind of critical mass on our understanding of pregnancy complications and cardiovascular disease. And are we reaching the point where actually we need to be doing a lot more of investigating and what those interventions could be? So electronic health records can provide some useful, maybe hypothesis generating kind of work in that area, in the sense that we can be looking, as you pointed out, Dr. Winger, to what kind of the optimal level of control of hypertension, perhaps during or after pregnancy. What about sort of cholesterol levels? How do they change over time? And do we need to target women who've had preeclampsia, for example, to get them on statins earlier? I think that if we're thinking about electronic health records, those are the questions we need to be looking at. What are those sort of trajectories of various cardiovascular risk factors in the years after affected pregnancies? And therefore, can that information be used to highlight when interventions need to be targeted? And then can we get some of the research done on those interventions? That would be the most amazing thing if we found out kind of the when and the where, and we could introduce that into guidelines. Because as we saw in the presentation, the guidelines they include pregnancy complications, but often it's the advice that's given is really generalized. It isn't particularly specific, and I think we might need to get a little bit more specific and a little more detailed, which will require a little bit more research, of course.
Let me ask you probably an even more difficult question, because it may well be that the social determinants of health may be important contributors. Given what you see from medical records, how can we ascertain elements of the social determinants of health for these young women that might place them at extreme risk?
Yeah, so the data that I have, we get deprivation, that's certainly available to us, but that's a composite deprivation, it's an area level of deprivation that we have access to. Individually, there isn't a huge amount to go on, that we don't record information on kind of levels of education or, perhaps income or anything like that. So it's really, really hard to get that individual level data actually from where I stand. Area levels, yes. And of course, being a population health doctor, that there is definitely some use in that for me, but I appreciate that in terms of kind of really skewering and identifying individuals, that's not the most helpful way of going about things. But is electronic health records the best way of going about getting that data? I'm not 100% convinced, because you have, confidentiality and identifiability and having to anonymize data. So I don't know if that is the data sets that we should be going for to work out that kind of that individual level of deprivation information and its relationship to obstetrics and cardiovascular outcomes.
Well, this tells us some of the limitations of these electronic health records in terms of using them as a source. And it says that perhaps there are things that are very relevant to what we call medical health, if you will, that probably should be incorporated in the standard electronic health records. There's a question for you that I think is challenging from Dr. Davis. Given the competing demands for women who've just given birth, how can we include them in the design and development of research studies? How can we involve them without taxing them more? Do you think we should do it postpartum or within 6 months of giving birth? Where should the studies start? What is your guide to the young researchers?
Oh, an excellent question. And that's one of the most challenging aspects, I think, about this is actually, like I said, not beating women over the head with things when they've just given birth. And also, how to do this research without burdening women who already have so much on their plate already. And personally, I would advocate for, as much as possible, the burden being placed on the clinical professionals who perhaps maybe are more capable of taking it rather than a woman who gave birth 2 weeks ago. In the UK, we have health visitors that come and visit. Is it possible for them to have sort of low level lying interventions, like taking blood pressure, monitoring blood pressure, a health visitor visits, which happen reasonably frequently, that wouldn't be too onerous for the woman, but it would perhaps identify hypertension sooner, and therefore, interventions, referrals could be possible. In terms of those lifestyle changes, however, that could be really slickly integrated into the social scene of newborns and new mothers, because there is a strong social scene, but often women can feel quite isolated in those weeks and months after giving birth. It could be a positive thing in women's life to say, okay, if you enroll in a study, you end up in a cohort of women, a group of women in a similar situation. You can talk, there can be emotional support, but at the same time, some of this may surround some gentle physical activity, going for walks with the babies and that kind of thing. I think it can be done, but it needs to be done with added advantages to the woman, or the kind of additional burdens to clinicians who I appreciate are already overburdened, so I don't need to speak too harshly there.
Let me ask you then, community. Obviously, this is a problem for the public health. Mm-hmm. How do you think we approach communities? You've obviously had a great deal of outreach to your local community and have been recognized for it. What do you think can be done in terms of community information, education, intervention?
Yes, that's a really, really interesting question there. And I'm all in favor of communities, like co-creation and the communities driving it forward. We need to go and talk to the communities and find out what's important to them. There is no point me kind of diving in and being like, okay, here's what I think you guys should care about, and what we should do about it is this. It will just fail. It needs to be community-led, community-driven, and that means going to them as agnostic as you can and being like, what are your concerns and priorities, just before pregnancy, during pregnancy, after pregnancy, what can we support you with and what can we help you with? Because this might be important to me, it might be important to a range of clinicians, and indeed it will be to some women, but other women, they may have had gestational hypertension or preeclampsia, but actually they have much bigger loads and issues to deal with, and that needs to be dealt with first before we even attempt to tackle something else. So yes, working in communities is important, but working with is the important part of that, working with them.
Let me ask you to give a brief checklist to the young researchers who are listening. If you would like perhaps 3 to 5 questions to be answered in the next decade, what do you think are the highlights of the questions that should drive some research relative to gestational hypertension in pregnancy?
Okay. So I would say, I want to know, does gestational hypertension cause damage in pregnancy that is long lasting, or is it reversible? I suppose that's 2. Is there damage from gestational hypertension in pregnancy? Is any damage reversible? How do we prevent the cardiovascular events that are so much higher in women with gestational hypertension? What can we do to intervene early? Are the rates of cardiovascular disease the same? Well, we know they're not the same, but really, can we really find which group of women are at remarkably higher risk of cardiovascular disease after gestational hypertension? Because there will be those pockets, those small populations of women who are extremely high risk, and how can we reach them? And finally, what I really want to know is, I guess, the question that I put out there, which is, should we be communicating, and how do we communicate to these women? And I think that's, certainly a cause for perhaps social research rather than the kind of the quantitative side that I do. But I think that that's incredibly important and really lacking as far as I can tell as well.
I want to thank you for a superb lecture, for allowing us to share your vision and for essentially giving challenge to the young clinician researchers for what is to be done in the future. This concludes the session. Congratulations once again on the award, and congratulations on a spectacular presentation. Everyone
thank you
have a
so
great
much.
day.
Thank you so much, Dr. Wenger.